Welcome to the Reducing Clostridium Difficile Infections Among Nursing Homes. Learn from a collaborative in Kentucky conference call. My name is Leslie, and I'll be your operator for today. At this time, all participants are in a listen-only mode. Later, we will conduct a question-answer session. Please note that this conference is being recorded. I will now turn the call over to Ms. Nancy McDonald. Ms. McDonald, you may begin.
Thank you, Leslie, and good blustery afternoon from wintry South Dakota. On behalf of the South Dakota Foundation for Medical Care and the Great Plains Quinn and the Great 8+ QIO group, Lori Hintz and myself welcome you to today's webinar, Reducing Clostridium Difficile Infections in Nursing Homes, Learning from a Collaborative in Kentucky, with featured speaker, Dr. Fontaine Sands. During this webinar, there will be a live chat box function that we encourage participants to use for comments and questions. We'll make sure we monitor that. The phone lines are on mute right now, but we will open lines at the end of the webinar for questions. And it is being recorded, and it will be made available to the QIO of each state belonging to the Grade 8+. You may also find the recording posted on the Great Plains Quinn website, which is www.greatplainsquinn.org under the calendar section. So for participants' convenience, the address will be posted in the chat box as well. Dr. Fontaine Sands is the Associate Professor of the Department of Baccalaureate and Graduate Nursing at Eastern Kentucky University. She teaches in the areas of nursing leadership and management and public health. She's also coordinated activities for the purpose of improving the quality of care and reducing healthcare-associated infections in Kentucky healthcare facilities. Dr. Sands is going to share with us today her work with 36 Kentucky nursing homes and how they successfully reduced the incidence of C-Dif infections by 15% and the use of antimicrobials for non-symptomatic bacteriuria by 25%. And I was one of the very lucky ones that got to listen to Dr. Sands present at the National Association of Healthcare Quality this last fall in Nashville. So it is with my extreme pleasure to introduce our speaker to you, Dr. Fontaine Sands.
Thank you, Nancy. Good afternoon, everybody. I'll let you know, even though I'm in Kentucky, we have your weather. Currently, our wind chill is between 10 and 20 below zero, which is uncommon for central part of the state. So we are also freezing here, as well as I'm sure many of you all are in South Dakota, North Dakota, and Nebraska. I'd like to begin. This was a collaborative project that was done while I was working also with the Kentucky Department of Public Health. I was the original infection prevention coordinator for HAIs for the state of Kentucky through the grant funding that was we received from the Affordable Care Act. We are one of the few states, actually in the United States, that has no mandatory reporting. So we did not have an established HAI program at our state Department of Public Health, which we do now. All right, so I have no disclosure. Again, I'm a professor at Eastern Kentucky University. Again, I have consulted and worked with the Kentucky Department of Public Health, and I'm also a consultant with the Association of Linen Management, which does a lot of stuff with linen, and I'm an infection prevention consultant for them. So basically, challenges. To begin with this topic, healthcare is getting more and more challenging. Mainly in the fact that years ago, several decades ago, when I began in nursing, which was about 28 years ago, we were pretty siloed in the way we looked at healthcare. You had the acute care healthcare, the hospital facility, the outpatient, and the long-term care really as separate. We all function completely separate. But in today's world, our patients are moving backwards and forwards and receiving care from multiple facilities. And when we think of healthcare-associated infections, we have to think past what we originally thought about, which was the hospital and the healthcare arena. The CDC, several years ago, Dr. Frieden, Thomas Frieden, who's the director of the CDC, outlined 6 winnable battles. These are all things that the CDC considers preventable and has dedicated time, resources to decreasing these. And healthcare-associated infections is one of those 6 preventable battles that the CDC is fighting. So long-term care is estimated that approximately 1.6 to 3.8 million infections occur annually in the long-term care setting. That is higher than what is anticipated and what you see in a lot of the initial studies, the error is human. That all came out, and a lot of that had to do with hospital-based, because that's where the majority of our data is. But it is anticipated that long-term care has a significant problem with healthcare-associated infections. Long-term care, as you can see here, it depicts from the Center of Medicaid and Medicare kind of skilled nursing facilities and where they're located. It's estimated that there's over 15,000 facilities with 1.4 million beds per CMS in the United States. So we have a lot of beds and a lot of facilities, way more than hospital-based facilities. It's estimated that 3 million residents receive care in certified nursing home or skilled nursing facilities in the United States. It's estimated that for-profit nursing homes account for about 70.5% of the facility types, non-for-profit nursing homes 23.2%, and government nursing homes account for the remaining 6.3%. Here is data from the Nursing Home Compendium that looks at nursing homes by year and bed size. And basically what we can see is there's been a slight decrease since 2003 to 2012 in some of the facilities and an increase in other bed size facilities. But overall, it's estimated that there is going to decrease of about 1.4% of nursing homes in the United States. So the percent of the state population 65 or older living in nursing homes, you can see here, and you can see and look at your state. For us, Kentucky, we ranked at about 2.8 to 3.3%, but your South Dakota, North Dakota, Nebraska, you all are at the higher end at 3.8 to 5.3% of your population 65 or older living in nursing homes based on the 2012 Nursing Home Compendium. The compendium also goes through and talks about the percent of nursing home residents with 4 to 5 ADL impairments. And the more impairments, ADL impairments, that a nursing home resident would have would place them at higher risk for possible infections just due to their chronic health and immobility and all the things that we know are risk factors. And again, you can see Kentucky, as you can see, is in the higher ranking states for the number of residents with 4 to 5 ADL. So that's how come we thought this, again, was an important thing to do for the state of Kentucky. You all in the Midwest are a little bit less than we are in the eastern part and the very far western part of the U.S. Kentucky also, the compendium, and you all can get this compendium, CMS, you can go out there and get it. Kentucky also broke down some of those quality issues such as injurious falls, pressure ulcers, whether or not they're being restrained, and incontinence, which could be an issue related to UTIs, was fairly high, 36 to 43%. Percent distribution of health-specific deficiency citations. So again, the compendium can tell you. So across the United States, basically there's been about a 5% increase in the number of greater than minimal harm. So in 2012, that kind of peak section has increased. Minimal harm decreased over time, but the greater than minimal harm has increased. Actual harm did decrease, and immediate jeopardy has been about the same across the gamut here. Percent of nursing homes with quality of care deficiencies by state. So this broke it down by state, and you can see your state in where they ranked. Kentucky ranked 2.9 to 5.4%, so we weren't quite at highest end, but we were fairly close by state to be at the higher end. So about 25% of the nation's facilities were cited for survey deficiencies for poor quality of care. And here were some of the major ones that were listed in the compendium. 34% for failure to meet professional standards, 30% for infection control problems, 29% for failure to provide comprehensive care plans, 24% for giving unnecessary drugs, 22% for poor clinical records, 21% for pressure ulcers, and 21% for poor housekeeping. And we kind of looked at this and said, okay, we've got 30% for poor infection control practices, 24% for giving unnecessary drugs, and many of those are antimicrobials, which is the #1 risk factor for C-Dif, and 22% for poor clinical records, and that'll be important as we continue to discuss. And then the 21% for poor housekeeping. C-Dif is an environmental contaminant, so housekeeping practices do make a difference as well. So here's some data that was presented by a CMS surveyor at a conference that I went to. And as we can see here across time, this is for the infection prevention and control CMS FTAG. And as you can see from 2000 to 2010, that first kind of orange bar is establishing an infection control program. And as you can see, that has definitely improved over time because now they'll get cited if CMS will cite them if they don't have an established infection control program. But the other ones clearly show that isolation residence when appropriate, that is the deep red one. You can see that that really has not changed or improved. This is percent compliance. So about 5% are getting isolated. Appropriate, prohibiting employees from coming in and having direct contact when they're ill, washing hands when indicated, and handling linens to prevent spread of infection. All of those are pretty much not improving in their compliance. So yes, they may have a program in place, but it doesn't mean that that program is actually changing practice within that institution to prevent the spread of healthcare-associated infections. So based off of all of the issues related to healthcare-associated infections, we do know that the Government Accounting Office presented to Congress saying that the federal government, that HHS, Health and Human Services, was not doing enough to prevent healthcare-associated infections. So due to that, HHS developed the action plan to reduce healthcare-associated infections across the United States. And we all are addressing that in our QIOs, in our states, to improve that. So in the NHS Action Plan, one of the major overreaching priorities is Clostridium Difficile infections. Also catheter-associated urinary tract infections, but at least in our state, our facilities, based off of our state regulatory and state inspections, the utilization of Foley catheters in our long-term care facilities have drastically reduced over probably the past 10 years. They do use them. We'd like to get them completely out, but really it's a very small percentage, and you'll see that as we go through our data. So we initially set this project to address Clostridium Difficile. We are addressing UTIs, but we're addressing UTIs as a whole and not just going in and focusing on catheter-associated UTIs. So if you do a project... So if you do address or decide to do a collaborative project, don't just pick catheter-associated UTIs. Look at UTIs, and you can look at the component of catheter, but also symptomatic urinary tract infections. So long-term care will be added to Phase 3 of the Health and Human Services Action Plan for prevention of HAI. So hospitals were Phase 1. Phase 2 were our ambulatory outpatient surgery centers, dialysis, rehab. Those have come up, and long-term care will be in Phase 3. So for Phase 3, the Long-Term Care Action Plan, there are already established priority areas. The priority area number 1 is to have enrollment in NHSN for nursing home infection surveillance activities. We did not select that as part of our initial collaborative, Phase 1 of our collaborative, because NHSN did not have their nursing home module at that time. They were working on that development. So we decided to look at priority area 2, which was Clostridium Difficile infection, and priority area 5, which was to address urinary tract infections, catheter-associated urinary tract infections, and catheter care and process reporting. So we decided to focus on those 2 priority areas to begin with in our Phase 1. So why is C-Dif still an important component that CMS has picked? So C-Dif is a bacteria that lives in the intestinal tract of humans. If you all don't know, humans are born with C-Dif in your colon. It's one of the bacteria that all babies are born with. So if we went into a hospital and into the nursery and we culture the stool of all of the babies, we most likely will find C-Dif there. What happens is your good flora, your E. coli and the Enterobacter, the bacteria that's there, that's your healthy bacteria, crowds it out. It doesn't allow it to overgrow and cause inflammation of the bowel and problems. And as we age, that crowding out, most adults actually, C-Dif will go away, and you won't find that no longer in their colon. But about 30% keep a small amount of C-Dif. So some people will have a positive culture for C-Dif in their stool, but without active disease, they're not infected, but we still can have carriers of C-Dif. As the number 1 organism causing HAIs, MRSA used to be that. Now, Clostridium difficile is classified as that number 1 organism causing healthcare-associated infections. So that's why it's become a priority. The infection occurs when the bacteria overgrows in the intestinal tract as a result, usually, of the loss of that normal flora. So if we give a lot of antibiotics and we're trying to kill off one bacteria, but we're also killing off our normal flora bacteria. And if there's any C-Dif present, it will be allowed to grow, and then it will invade the colon, and it will cause disease, which includes symptoms such as watery diarrhea, abdominal cramping, colitis, which is inflammation of the colon. It can actually cause what we call megacolon sepsis and death. So it must be treated. It cannot be left untreated. So here's some data that I came across with a presentation, and basically it is that approximately 69 to 80% of reported Clostridium Difficile infections occur in adults age 65 and older. And we know what predominantly is in our long-term care facilities is our older adults. So they're at a high risk for this. And as you can see, nursing home onset, they're looking at approximately 263,000 cases annually with an excess cost of $2.2 billion and over 16,000 deaths annually that occur related to C-Dif in long-term care. So why are people 65 and older at increased risk? One, age-related decrease in gastric acid. So as we age, our gastric acid decreases, and bacteria may bypass that defense mechanism of that gastric acid. Also, younger people who are on what we call proton pump inhibitors, drugs, if they have gastric ulcer or reflux disease, we're artificially decreasing that acid, and so we are seeing some cases of C. difficile in people that have not been exposed to antibiotics that are developing it, and it may be related to that decrease of acid function. Residents in hospitals and long-term care facilities, so also when you're 65, you're at higher risk of having more healthcare needed and interfacing with the healthcare system. Overuse of antimicrobial medications. We seem to use it more in our older adults. They have chronic diseases. Their immune system is also waning, and so they are higher risk and have higher repeated infections. And the risk of cross-contamination is substantial. They have a high prevalence of incontinence when they're nursing home bound. They're also sharing bathrooms, dining facilities, rehab facilities. That's one of the challenges that's different for the long-term care facility than the hospital is the long-term care facility is designed to be a group setting to increase and to provide that interaction between the residents. Where in the hospital, there's usually, besides if you're in have a roommate, they're not going to a lot of places, and they're not eating their meals in a major dining room. If they go to physical therapy, there's usually only one of them. There's not really group physical therapy or group activities and art and things like that. So in the state of Kentucky, we received some ACA and ELC funding in September of 2011 to conduct a collaborative study in the long-term care arena to try to reduce Clostridium difficile. Our kickoff was in February of 2012. I designed this project when I wrote the grant to be an 18-month project. And that was just for phase 1. We also then conducted phase 2, which I'll talk a little bit about at the end. But just phase 1 was an 18-month project. We had 36 long-term care facilities that volunteered to participate. And you can see here the counties in blue were where these facilities were. Some counties had several facilities. Other counties just had one facility that participated. But it gave us a good across the state participation. So I want to step off just a little bit about our project and just talk about when you're doing quality improvement projects, and why, when I designed this for an 18-month project. And that was a little challenging, especially for you all that are receiving grants through the CDC. Those are 12 months, 1 year grants, and by the time you get notified that you got the grant money, you're already into that fiscal year grant cycle, and so you really don't even have 12 months. But I designed it so it would go over 2 of those cycles, and the reason I did that is because when you're looking at changing behavior, which a lot of this is, it's changing behavior. I wasn't doing research to determine what the evidence-based practice is. We know what we need to do. We have to get people to change their behavior and actually function in those evidence-based practices. And we know from behavioral health research that behavior change is one of the hardest things to do. And if we look at some of the theories that are out there, Rogers' diffusion of innovation theory clearly says that you have different types of employees. No matter where you are and in what setting, it will usually follow the normal distribution curve, and that's what that curve is. And so at the far left, about 2.5% of the people that you're trying to get to change their behavior will be classified as innovators. And these are actually the people that are coming to you and say, we need to change practice. We need to make it better. They're the ones usually bringing that to you. 13.5% are what we call early adopters. And so it's easy to bring them on board. Usually you just have to show them and educate them and do an educational program and say, okay, here's the evidence. This is the way we're supposed to be doing it. Here's the data, and they're on board, and they'll do it. So your innovators and your early adopters, you can usually get in the first 3 months. So if you schedule a project, and your project is to have it completely done in 3 months, the only people you're going to get on board is 16% of who you're trying to change. Early majority is the next group of people, and that's about 34%. And it's going to take another 3 months to get them on board. You're going to have to do more convincing, and you're going to have to show them that it's not going to impact their work productivity, that it's not going to cause a lot of extra steps or it's going to make it hard on them. So 6 months, you're going to get about half of the people you're asking to change. The second 6 months is you're going to get the late majority and then your laggers on board. So truly, to get through each one of these groups, at minimum, it's going to take you a year, 12 months. So when we look at behavioral health research, whether it's related to smoking cessation or weight loss or any of those things, it shows that it takes time and it takes ongoing support. So you can't do a project and say, okay, I'm going to give you all this information up front and then we'll come back and we'll reassess later and see how you did. Well, you're not going to get those late majority and laggers to change their behavior unless you have ongoing support to help them. So we designed this 18-month project over long periods of time, as well as we were there giving them support through the whole process. And in long-term care, I do recommend that you do that because the people that are in the IP position, many of them have absolutely no training. They don't even know what the evidence-based practice is. You're basically taking everyone, including the IP, on this journey. They can be there to help you, but they also need that education and that support through the whole system. So our collaborative facilities that agreed to participate in Kentucky, we surveyed them up front, and basically this is what we found. 53% were independent, freestanding facilities, so they were not associated with a hospital. 47% were for-profit, 41% not-for-profit, and 12% were considered a government facility. The average bed size was 102, and the average length of stay was 285 days. The majority of them provided long-term skilled care, long-term general care, short-term subacute care. 69% provided long-term dementia care, and 69% hospice and palliative care. And then we had a very small subset, which one of them was a government facility, and that's all they did was provide long-term psychiatric care. The infection prevention staff in the long-term care facilities, when we surveyed the facility, we also surveyed them, and their experience, on average, the median was 3 years. So these people in these positions were fairly new to these positions. Their educational level, less than 9% had a bachelor's degree or higher. So most of these nurses were either associate nurses or LPNs. Few of them had any higher degrees. 0% were certified in infection control. So they had not verified that they had any basic level knowledge of infection control practices because they had not taken a certification exam. 73% spent 50% or less time on IP functioning, meaning that, yes, they were the infection preventionists for their facility, but they also had other duties that took away time being spent on this. And that was impacted our collaborative study because some of these facilities ended up stopped collecting data or entering data because of the time constraint that was added to this. And then 48% actually received no training, meaning there wasn't somebody in-house that trained them. They had been to no state training course, no national training course. 48% said they had absolutely no training whatsoever concerning infection prevention and control in their facility. So our study objective, our primary goal for our collaborative was to reduce the incidence of Clostridium Difficile infections by 15%. But in order to achieve that, we knew that the number one risk factor for C-Dif is antimicrobial use, is the overuse of it. So our secondary goal to get to that, we needed to reduce the use of antimicrobials for non-symptomatic bacteriuria. So these are patients who may have positive cultures that they are exhibiting absolutely no urinary symptoms. In the IDSA, the Infectious Disease Society of America, which is a national organization for infectious disease specialists, basically says you should not be treating asymptomatic or non-symptomatic bacteriuria, especially in our elderly, because we know that their bladders will become colonized with organisms over time, especially as they're immobile and they have incontinence, or males that have enlarged prostates and difficulty emptying their bladder, decreased fluid intake. All of those increase bacteriuria. But if you're not symptomatic, you shouldn't be treating it. So we needed to address that as well. And our goal was to try to reduce that by 25%. And here you can see in the United States here, antibiotic prescribing rates by state across the U.S. This is from a study that was done 2011-2012 in Kentucky, that southern belt. There is some of the highest states. Now, North Dakota, Nebraska, and Kansas, you all are in that second to highest category for antibiotic prescribing based on this study. So antimicrobial use in nursing homes, based on some of the information the CDC provides and some of the studies, that they're the most frequently prescribed drug class of all drug classes. They comprise 40% of all prescriptions are antimicrobials. 50 to 70% of long-term long-term care residents will receive an antibiotic every year, annually, for some reason. 25 to 75% of antimicrobial use may be completely inappropriate, meaning they're being given, but they're not being given for the appropriate reason. So we have a lot of overuse of antimicrobials, and it's probably why Clostridium difficile is now so high in the United States. So when we look at infections in long-term care, what are the most common infections that we know are being treated with antibiotics? So urinary tract and respiratory tract infections are the two highest. Then skin and soft tissue infections. Then there's a category of other. And then in this one study, there was 13% were completely undocumented. They couldn't find in the documentation, the clinical documentation of why the antibiotic was being prescribed. So we know that we do have an issue with, again, possibly inappropriate use of antibiotics. So this 18-month project, again, began February 2012 and ended phase 1 in July 2013. The first 6 months, we had to collect pre-intervention data. Since Kentucky was not a mandatory reporting state, we had no data really from our long-term care facilities to be able to even say, to be able to compare once we did do an intervention whether or not we impacted. So during the first 6 months, we did a lot of education for our IPs. We set up our surveillance system, educated them on their surveillance system, and collected data. Then we looked at and developed our interventions, and then we did 6 months post-intervention data collection. During this whole process, these 18 months, we did monthly conference calls with all of the IPs, and we had 4 in-person educational trainings on top of the initial kickoff meeting. So 5 times we came together at one of the state parks, and we met in person. The other times we were on conference calls talking about how they're doing, answering the questions that they were having. We also went to each of the facilities to validate their data collection as well and look at their facilities and answer any questions that they had. So we also made a site visit to their facilities. We used the NHSN Long-Term Care UTI and CDI surveillance definitions. These were provided by Dr. Namali Stone at DQHP. Again, at that time, the NHSN module was not available, so we didn't have those data definitions. Dr. Namali Stone, who's been heading that at the CDC and HHS, actually did provide this for us so we could use it in our collaborative project. Because there was no database, NHSN database, we had to create our own, and we used SharePoint on our state server to do this. As you can see across the top ribbon there was a urinary tract infection tab, and they could open that up, and that's where they could enter their UTI data, their CDI events, their monthly data, which was their resident days, their catheter days, and that type of data. And we posted a calendar on there, shared documents. When we did an educational session, we put the PowerPoints out there. So we had another way to communicate with them. All of our emails, contact was there, so they could kind of go one-stop shop place. So you might think about creating, if you can, they can put the data in NHSN, but you might also think about creating a SharePoint site where you can communicate with them and they can go find documents and things that you might post for them. So what improvement activities did we actually do in the collaborative? Well, the first thing we did, again, was develop and educate them on surveillance methods and how to use the NHSN surveillance definitions and how to apply those to the cases that they were seeing in their facility. Using that surveillance definition, we helped educate them and help them understand and identify the difference between symptomatic versus non-symptomatic UTI events. We improved their knowledge level of the facility IP on transmission of disease and infection prevention and control practices. Again, many of them had no training whatsoever, and they had tried to learn some stuff on their own, but they really didn't quite understand it. So we went back through all of the basics. We talked about environmental cleaning procedures, use of contact precautions and PPE, collection, storage, and transport of their urine specimens and C-Dif, the use of urinary catheters and the care, all of those evidence-based practices that are there. So we hit on those topics that we knew they needed to understand to really prevent Clostridium Difficile and UTI infections in their facilities. We provided them with resources. One of the things that we found when we went in and we did our site visits and we were looking at them and they were showing us some of their manuals, some of these facilities, looking at just even their policies, it was maybe 5 bullets on a page that bulleted a couple of things. I mean, some of these facilities really needed a lot of help. And because they're time constrained, well, we found out that because of their time constraint, we couldn't tell them, go do this, this, and this, and this. One, they didn't know how to do it. And two, they didn't have the time to be able to set aside to do those as quickly as we needed. So we basically took a basic format of a policy and put it out there with the evidence-based practice in it and said, okay, modify these into the format that your organization wants to use, have them vetted by your policy committee, put your name at the top, and then adopt these as your policies if you don't have a policy already in place for this. So we created policies for them to potentially use. Monitoring tools. We pulled monitoring tools from all different aspects, from studies that have been used, other projects that have been used, things from APEC, which is our Association of Professionals in Infection Control, from the CDC, from IHI, all of those places that had bundles and things that could be used. We pulled those tools together and we offered some of those to them. We created algorithms and decision trees. I know when you're out on a unit for a nurse, if they can see an algorithm or a decision tree versus a policy, it's a quick visual reference. They can go down it. They can see which direction they're supposed to go, what the next step is, and that really helps at the clinician at the bedside to have those algorithm and decision trees. Skills checklist. If they needed to check off, those staff that were inserting Foley catheters, you can have high contamination rates and introduce organisms that they have skill checkup with. Being able to collect a specimen correctly was an eye-opener in the long-term care arena. Teaching PowerPoint. Some of them didn't know how to create a PowerPoint to be able to use to be able to educate their staff on some of the changes. So we created some basic PowerPoints and slides they could use to be able to then teach their staff in their facilities. Case scenarios so they could understand the surveillance definition and how to apply them. And we did also purchase with the grant funding some of the APEC resources for them because some of their facilities, they didn't have any hard copy resources that they could go back and re-reference. Some of these have changed. APEC has updated them. The C-Dif and probably the CAUTI have been updated, but we did purchase them some resources as well. So here's just an example of a policy. Here's just an example of algorithms, decision trees that we did. Again, we also did a little bit of an empiric antibiotic therapy guide. We had a pharmacist on our team to kind of give the physicians, the clinicians, an idea of what might be some appropriate antibiotics. Our analysis of our results, basically it was 18 facilities that, of the 36, that actually completed good data final collection that we could use in the analysis. We surveyed the facilities to find out what of all of those policies, algorithms, all of those things that we actually developed for them or we asked them to implement, we wanted to know which ones they actually did. And as you can see, in the majority of them, the last one used post-catheter assessment decision tree was a little less than 50%, but the majority of them were using a lot of the stuff that we asked them, that we provided for them. Our results, as you can see, in total we had almost 1,500 UTI cases that were entered into the database. Of those, 24% were symptomatic UTIs. Only 3% were catheter-associated UTIs. So again, if you just go after catheter-associated UTIs like we do in the hospital setting, you're really not going to make a big impact. And then asymptomatic bacteriuremic, so a booty is actually a bloodstream infection related to it, was very, very low. But the biggest portion of the cases that were reported, 75% of those almost 1,500 cases, actually fell into the category we call the MD diagnosis. That means it did not meet criteria for SUDI, COS-SUDI, or a booty. So this was the problem that we were seeing, is that we had all of these cases out here that were being treated with antibiotics that really didn't have symptoms or meet even a surveillance criteria of a possible UTI. Urine cultures were obtained about 84% of the time, but that meant 16% of the time we had residents out there being treated with antibiotics and no culture to even identify the organism that was being treated. Now, some of those, a UA was being done, but that's a screening tool. It's not a diagnostic tool, and it cannot tell you for sure that there is an actual symptomatic infection occurring. The way the specimens were collected, 41% were voided, 41% were in and out cath, and 8% were from indwelling catheters. The top three organisms, E. coli, Proteus, and Klebsiella, that's what we found. That's what the literature says are the top three organisms in previous studies that have been the top three antibiotics prescribed with Cipro, nitrofurantoin, and Bactrim. And the concern we had here is in the elderly population, nitrofurantoin, macrobid, and macrodantin, you need to have creatinine clearance, or you need to know what that is, because in the elderly, this can actually harm their kidneys. And so, but we were finding that nobody was checking creatinine clearance before they were prescribing this antibiotic. So there was an issue with antibiotic prescribing. Our results here, this is pre-intervention. You can see these are some of the symptoms that are part of the NHSN surveillance definition criteria for a UTI. And what I've got focused in the red is what I want you to focus on, none. And look at that MD diagnosis category. Almost 67% of the MD diagnosis category being treated with antibiotics had no fevers, no rigors, no hypotension, no confusion, no pain, no dysuria, no purulent drainage. They had none of those symptoms. I'm going to skip this just for time. And then if we look at the true urinary symptoms, urgency, frequency, incontinence, suprapubic tenderness, gross hematuria, posterovertebral angle pain, again, none. 82.52% of those in the MD diagnosis group had absolutely none of those. Now, you're probably seeing the ABUDI, and it says 100%. That's because it's supposed to be 100%. To meet that definition, they're supposed to be completely asymptomatic of these urinary symptoms. So that's a good thing to see it there. But the MD diagnosis, again, if they have no symptoms, why are we giving them antibiotics? So basically, here's our final results of our UTIs. So these are all of the UTIs. These are all grouped together. And we had a total of a 27% reduction from our pre-intervention to our post-intervention. And that is significant, that 27% reduction. If we look at just the MD diagnosis group, so this is basically the asymptomatic bacteriuria. And our secondary goal was to have a 25% reduction in that group. And we actually achieved a 33% reduction in this MD diagnosis group from pre to post, and that was statistically significant. Now, you may be asking, how come the overall was 27, but yet I saw a 33%? The reason is because we improved their surveillance, we did see a slight increase in the pre- and post-SUDI category. Not that we think that they had increases actual infections in that group, but we improved their surveillance so much that they were identifying actual symptomatic UTIs that they had not categorized in that category. And mainly that was due to documentation, because the documentation was poor, and we improved the documentation. So when we look at outcomes, one of the things that also is not just the infection, but what is the result of mainly antibiotics. When you're trying to convince physicians and nurses and staff not to give antibiotics, you want to look at outcomes. So we looked at our pre-intervention and our post-intervention related to hospitalization and mortality. So this is hospitalization here. And as you can see in the pre-intervention, the top level, 78 of the residents had to be transferred to a higher level of care. Post-intervention, only 50 had to be transferred to a higher level of care. But if you look over to the bottom table in the far right, the p-value is 0.62, which means the difference is not significant. So we can definitely say that no more patients needed to be hospitalized because we didn't give them antibiotics. It didn't harm them. They didn't have to be transferred to that higher level of care because they got septic. So it didn't impact them clinically because we did not give those antibiotics. And here, if we look at mortality, again, pre-intervention, 36 residents died within that 30-day criteria, and post-intervention, only 8 died. And that is statistically significant. The reduction is significant. So we actually reduced mortality between the pre-intervention and post-intervention group by not giving the antibiotics. CDI cases, so that was our primary goal. Total, we had 80 cases that were reported. 65% were classified as new and 35% were classified as recurrent. That's part of the CDC and HSN definition. What we found was that 63% of those that developed C-Dif actually had received antibiotic therapy in the previous 30 days. So decreasing that antibiotic use can and should impact your C-Dif rates. We did find that most of them were being put into contact precautions, which was good. And our overall goal was to reduce C-Dif by 15% over our pre-intervention to our post-intervention time. We actually got a 43% reduction, which was statistically significant in our rates of C-Dif by improving our environmental cleaning practices, their PPE use, and their reduction in antibiotics. All of those interventions that we did, we definitely got a significant reduction in our C-Dif. If we looked at outcomes, death and hospitalization, our pre-intervention, we had no deaths within 30 days of their C-Dif as well as our post, so there was nothing there. But our hospitalizations, again, 6 required hospitalization pre-intervention, only 4 post-intervention. Statistically, there's no difference in that. So again, we can say not giving the antibiotics and making the changes did not increase the risk to the resident of hospitalizations and mortality, that there was no significant difference, but yet we decreased their infections, which again we know is a great thing for our residents. So lessons learned, not enough time dedicated to the IP function in the long-term care facility. Somehow long-term care is going to have to address that. Assessment and documentation of UTI symptoms definitely needed improving. So up front, if you do a project, realize that your documentation to be able to apply those surveillance definitions need to be addressed, and you need to look at how the nurses at the bedside are documenting those symptoms. The other thing we learned that in long-term care, across the board, all the facilities, if the resident became confused or had any behavioral change, they automatically said that's a UTI. They didn't even look for other symptoms. They just said confused, they have a UTI. They called the doc and said, they're confused today, I think they got a UTI, do you want to treat it? And so the physicians are not in-house like they are in a hospital. They come once a month maybe to see these residents. They're not going to make a special trip over there. So what do? They play defensive medicine, and nurses called them, told them they think they had a UTI. So what do? They treat the UTI. So we had to convince them that confusion and behavioral change is not a direct associated link to a UTI. Long-term care staff communication can definitely impact the provider prescribing. They can definitely do that. If the nurse doesn't lead the physician in or isn't collecting and looking for all of the symptoms and communicating that to the provider of the phone, they don't know how to treat appropriately if they're not getting a full assessment. Urine specimen collection, storage, and transport was definitely an issue. Some of these long-term care facilities were taking speci-habs, non-sterile speci-habs, putting them in the toilet seat, having the resident urinate in those speci-habs, and then pouring that into the sterile container and sending that as a sterile specimen. Were they pulling clean speci-habs every time? No. They would spray the speci-habs thinking that they were cleaning the speci-hab, and then they were having them voided. So that was a huge issue doing that. If they're not stored on ice or in a refrigerator and at a lab, then that's an issue because organisms will start growing and colonizing in those containers. There was a lot of issues around that. And then, of course, environmental disinfection needed improving, and their cleaning processes, their products. Some of them thought because the label said kill C-Dif, then that it was okay, but it was in the vegetative state. It wasn't in the spore state, so some of the products they were using to kill C-Dif were not appropriate. So there was just a lot of issues that we had to go through with them. So I'm going to stop here, and if we have time, anybody wants to talk about phase 2 and where we went from there, then I will go over that. But just for time, I'll stop here and answer any questions that people would have.
Thank you. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. So once again, if you have a question, please press star, then 1 on your touch-tone phone. All right, first question from Marge Freiberger with Heritage Community. Please go ahead.
Hi, good afternoon. I'm just wondering, since you've obviously talked with a lot of different facilities with your research, do you find that one of the most useful tools for training staff is the Interact Care Path for UTIs?
I think each facility kind of has to figure out what works best in their facility. Some of the infection preventionists said, it doesn't matter what I develop and I present. The staff don't believe me. Will you come? and present and talk to my staff. And so there were some facilities that I made another trip, and I went down and I actually sat down with their staff. I answered their questions. I did presentations for them as some coming out. And so I was basically, I still wanted their IP to do a presentation, and I was coming down and saying, yes, your IP is correct. I was trying to build their rapport. One of the things we did in phase one, one of the things we didn't do in phase one is we didn't highly include the physicians. The medical directors knew that we were going to do this. We sent them all of the information, but we didn't ask them to heavily participate. We didn't become the intermediary between the IP and the facility and their physicians. We wanted the IP to be going to their physicians and saying, okay, we're going to do this project. This is what we're going to do, and try to engage them. The same with their staff, because we wanted to build them up as the expert in their facility. But if they did feel like they needed us to come down, then we would take whatever they wanted us to look at, go over, and help them convince some of their staff this is. And basically, again, if you look at that normal distribution curve, I was convincing the late majority in the labbers.
Okay.
I was convincing those hard-to-convince people that this is really what you need to do and change your practice. The pathway tools, really, I think, to me, I'm a visual person, and again, you have to kind of know what your staff is. I like to see algorithm and decision trees. The policies are there because you got to have them on there, and you can go back and reference them and understand why I'm doing it. But anything visual that you can use to have there tacked up and kind of say, okay, I need to collect a urine specimen. Here's the algorithm of getting this ready to be sent to the lab.
I appreciate that. Thank you, because we've been working on this for over a year, and what you're saying is just ringing so true with any kind of level of consciousness change, naturally making people think it's got to be urine, and it isn't always urine. So that algorithm is very helpful.
Yeah, because I kept telling them, I said, okay, confusion. What's the number one thing that immediately causes mental status changes? Well, of course, a stroke, a head injury, but hypoxia. Are you going in and checking everybody's oxygen level? I mean, hypoxia is going to cause confusion before a UTI. Sepsis will cause confusion, but I've completely missed the boat if I'm waiting until they're septic. But a UTI in itself is a localized infection in the bladder. The symptoms are bladder symptoms. Confusion and behavior change are related to sepsis, bacteriuria, not the UTI, unless it's progressed to that point. So, yeah, it was educating them, and a lot of them, needed. They had been out of nursing school for a long time, and again, in long-term care, again, you don't have a lot of bachelor's prepared, master's prepared nurses, a lot of LPNs and nursing assistants, and they need that education.
And it's not always just a quick fix. You have to actually research and think what's going on with that individual.
Head-to-toe assessment. You got to go back to the head-to-toe assessment.
Really do. Thank you. I appreciate your answer.
Okay.
Great. Next question from Sandra Blagat with Good Samaritan. Sandra, your line is now open. All right, we'll go to Michelle Hargaden with Montana Mental Health.
Hi. I was listening to you about the MD diagnosis and the high percentage change from the other results, and I'm not sure the terminology used or the criteria used, and I don't really understand that. I was wondering if you could explain how that could be that big difference.
From the MD diagnosis versus the NHSN definitions?
Well, you're giving me symptomatic UTIs, and then MD diagnosis. Is that significantly different, the criteria?
Well, we just called it that because there wasn't it's really asymptomatic bacteriuria would be probably the medical definition. But again, because I was dealing with some staff, asymptomatic bacteriuria is not necessarily something easy for them to understand. So we just called that category. The physicians were writing a UTI diagnosis, but those patients they were writing that diagnosis and treating with an antibiotic did not meet a C-Dif criteria. Now, those were MD diagnosis cases too. We just called it that. Technically, that category is asymptomatic bacteriuria.
Okay. All right. Thank you.
A symptomatic UTI case. They don't meet a catheter-associated UTI case, and they didn't meet the asymptomatic bacteremic UTI case definition. They didn't meet those three criteria. So we just said it actually belongs to the long categories, MD diagnosis, but does not meet any NHSN criteria.
All right. Thank you.
But they're all MD diagnosed. Every one of those, the physician was diagnosing a UTI. This group really would be classified as an asymptomatic bacteriuria case because they didn't meet a symptomatic case and they didn't have a Foley catheter in place and they weren't bacteremic.
All right. Thank you.
You're welcome.
All right. Next question from Pat Baker with Cherrywood Nursing.
I just want to clarify that not all physicians, the nursing home, in our facility, we do have physicians that do come over here 4 times a week. I just want that to clarify that a lot of our infections in relation to urinary tract infections, we look and utilize the McGrair statistic or the process of determining an infection. And if the person we look at and the lab result does not execute or demonstrate a urinary tract infection, our physician will give some explanation why the process of treating a UTI versus non-treating an observation. I just want to let you to share our process here in our facility.
Thank you. You're very lucky that you have physicians that come that often. One of the things that you need to go back and look at is the McGeer definitions were just updated in the last year. Dr. Namali Stone is the lead author on that. They now coincide with the NHSN definition. So the McGeer definitions have changed. So if you're still using the old McGeer definitions, you need to pull the new literature, the new articles that are written, and change your process of how you identify if you're using the McGeer. So like in our state, the state regulators, our OIG, their manual for state certification still have that to use the McGeer definition. But we have to tell the facilities now, if that's what you want to use versus the NHSN, you need to go back in your policies and in your process, and you need to change it because the McGeer definitions have changed now, and they do match the NHSN. And they did that because NHSN is going to be the national repository for your data, and everybody has to use the same data definition. So eventually, long-term care will have to join NHSN. They will have to enter data into NHSN, and they will have to use those definitions. So knowing that, that's how come we went ahead and had our facilities switch over to the NHSN data definitions. At the time, we didn't know they were going to go back and update them a year, so we asked them to use the NHSN because we know that in the future they're going to be mandated to go to that. And at least now I know my facilities, those that participate in the collaborative know it, they know how to collect the data, and they know how to enter the data.
Thank you.
Okay, next question from Ginger Neal of Fort Healthcare.
The E. coli.
Oh, Ginger Bailey, your line is now open.
Oh, hi, yes. I'm from Board's Healthcare in Green Lake. What we did is, this is just like a comment. We were running 7 or more UTIs a month, and what we did in the facility is I printed the McGear criteria. We in-serviced all the staff and the doctors and created a form that the nurses have in their 24-hour book that if a resident starts showing symptoms, they put their name, they put the date, and what it is. And then at that point when they have the 2 to 3 symptoms, then we collect the CNS of the urine. Now from November and December, we've had 1 to 2 UTIs.
Right.
So we've really made a drastic decrease.
Absolutely, and again, that's actually helping the nurses identify those symptomatic urinary tract infections that are appropriate and need treatment, and not identifying those asymptomatic bacteriurias. I mean, if I went through a long-term care facility right now and urine cultured every resident that was in it, I'm probably going to find 30 to 40%, depending on male and female, that are going to have positive cultures and absolutely no symptoms. And that's what you don't want to find.
Exactly. So, yeah, we're pretty excited about it because, like I said, we really decreased. And it was hard getting even doctors on board because as soon as somebody would have, like, you know, a behavior problem or something, we'd be getting CNS of the urine. And how many times, like you said, does it show that they have greater than 100,000, but they don't have the symptoms to actually say, hey, it really is a true infection. So we're happy here that we've decreased it.
Yeah, and what really helps is having that form.
Yes.
Having something that the nurses, if they want to suspect, so that's what we did with the decision tree, is if you have a change in a clinical change, you are obligated by regulatory laws to notify the physician that there's a clinical change in your resident. Well, before you call them, you need to go do a good head-to-toe assessment. If you want to suspect an infection and or a UTI, then this is what you need to assess for before you call the doctor, so you can give him all of the appropriate information, and then he can make a clinical judgment of what is in the best interest of the patient.
Exactly.
And you have that documented, so when the IP has to then go back and use the surveillance definition and determine what's going to be entered and under what category, they have the data that's documented there, and they can do that.
Yeah, we also, our individual infection report, we changed that too, and we made it to, is McGear criteria met for infection, yes or no, and we added that to our infection report, so that really helps us too. So we did a couple things.
Are you using the new McGear definition?
Yes, we are, and I created the form for the nurses here, and it's really simple because it's like a log, and we actually put them all in there, and we made it go right across. And the very last box says, you know, CNS of the urine ordered, yes or no, and then we also had a place about the antibiotic started. But the nurses are so aware of this, and they're so on board now, so that really helped us. And then our infection report, like I said, we did change it to add, is McGear criteria met or not met? If it's not met, we go to the doctor and say, okay, listen, we only had 2 symptoms, but you still wanted the antibiotic. We need documentation, so he will back us up on, as to why he might have done it.
Right, and we always tell the physicians we're not telling them, dictating their practice. But a lot of times they're playing defensive medicine, and if you give them all of the data and they can understand and make a clinical judgment. And then in our phase 2, we brought our medical directors and we actually established each case that fell out, like kind of like what you're saying is those cases that didn't meet definition. Then those are discussed in the IP committee and the medical directors there, and you're discussing each individual case, and you have that physician sitting there saying, okay, can you help us understand why this would have been medically treated? If the medical director says, well, it still shouldn't have been treated, then it's his responsibility to do peer-to-peer discussion if it was another physician that's practicing in that facility to help bring them on board to help them stop doing that practice.
Exactly. Thank you.
Well, this is Nancy. Can everybody hear me?
Yeah.
Dr. Sands, I think we're about at our time. We do have one or two questions in the chat, and they wanted to know if any of the tools or algorithms that you have listed in your PowerPoint presentation could be made available to the group.
Yeah, I think they're on the Kentucky's HAI website. So if you just Google HAI Prevention Kentucky and see if you get to the Kentucky HAI Prevention website, you may be able to get those. If not, I will let me know, Nancy, and I will try to get those sent to you so people can look at them and use them. I mean, it's all evidence-based practice. We didn't create anything new. We may have put them in different formatting and different ways to look at it, but it's not anything proprietary as far as I'm concerned because it's all evidence-based practice. We did some legwork to create it, but, at Kentucky, we're more than happy to share those with anybody.
That sounds great. Thank you so much. And with that, Lori, do you have anything else to add?
No, I guess, let's see, we had one other question here that just came in.
I noticed somebody asked what NHSN stood for. And
I got that one.
Okay, so that's the National Healthcare Safety Network. This is a component of the CDC, the Centers for Disease Control and Prevention, and it actually is the national database that all of the hospitals, rehabs, and dialysis centers now have to report their healthcare-associated infections to, and long-term care will also eventually have to do this in the future as well.
Well, thank you again very much, Dr. Sands. We appreciate your time, especially with the blizzard down in Kentucky, and I know looking out my window here in South Dakota, the blizzard and wind chill temperatures and all that, and everybody was still on the phone today. We had over 300 participants, I believe, at one time. And so I hope everyone on the line has enjoyed themselves and will have a few things to take away from today. And that concludes our presentation. So everybody have a great rest of the week.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.